All right. Good afternoon, everyone. Welcome and thank you for joining us today. We are really glad that you're here for this session on the 2025 American Heart Association um, and American College of Cardiology guidelines on high blood pressure. And there are some meaningful updates in these guidelines that we think will be directly relevant to your practice. Before we get started, if you haven't already registered for tomorrow's webinar, please do so. The registration link will be shared in the chat. And we're so glad that Dr. Dixon will be back with us tomorrow for a deep dive into the updates on dyslipidemia. So if today's session is useful, you don't want to miss tomorrow's. So really quick overview. My name is Jen Swanstrom. I am the manager of the Heartbeat program. As you know, cardiovascular disease is the leading cause of death in the US, and the greatest risk factors are high blood pressure and cholesterol, which is why we're focused on those. And this state receives funding from the Centers for Disease Control and Prevention to implement and evaluate evidence-based strategies that contribute to the prevention and management of cardiovascular disease, which is also known as Heartbeat California. We just started year 4 of our year 5 or our 5-year cooperative agreements. And at the end of last year, all of our projects surpassed our performance measure targets for achieving patient blood pressure control throughout the year. And that's due to all of the hard work and dedication of our projects and all of the screenings, education, and support that they provide to patients. We're currently in the process of gathering our evaluation data from this last fiscal year. We will be sharing those results in the next month or two, hoping to see those trends continue. We'll be reporting out at the next Healthy Hearts California Learning Collaborative meeting this fall, and you can reach out to me directly if you want to be added to that email list. Next slide, please. So today we'll be covering um, a walkthrough on the significance and prevalence of hypertension, move into how those guidelines approach diagnosis, cover treatment goals and management, and then close out with patient case scenarios to put it all into practice. And we'll also have Q&A at the end. So if questions come up during the presentation, please share them using the Q&A feature, and we'll get to as many of those as we can at the close of the session. Next slide, please. And now it's my great pleasure to introduce today's presenter. So Dr. Dave Dixon is the Nancy and Ronald McFarlane Professor of Pharmacy and Chair of the Department of Pharmacotherapy and Outcome Sciences at Virginia Commonwealth University School of Pharmacy, with a joint appointment in the Division of Cardiology at VCU School of Medicine. He brings deep expertise in cardiovascular pharmacotherapy, and we're really fortunate to have him with us both today and again tomorrow. Dr. Dixon, I'll turn it over to you. Thanks so much.
Thank you. Fantastic. Really appreciate the kind introduction and the opportunity to be with you all today and tomorrow. So be sure to chime in tomorrow or check in tomorrow with our dyslipidemia session. So today, what I want to do is focus on three main objectives, and we're going to review the prevalence and significance and diagnostic approaches for hypertension, discuss some of the recent updates there. We're going to talk about treatment goals for adults with hypertension and the role of current and emerging antihypertensive pharmacotherapy, and of course, apply the current guidelines that we have to patient scenarios so that you can have a little bit of a understanding of the application of these guidelines and how they impact treatment decisions. These are some commonly used acronyms that you'll see throughout the presentation. So let's jump in and revisit the significance of hypertension. I don't think that we can say this enough, but hypertension is, of course, a significant contributor to not just an increased risk of cardiovascular and kidney-related diseases, but it's also becoming more and more apparent that high blood pressure plays a role in cognitive disorders as well. So this is generally an asymptomatic disease. and a primary or contributing cause of over 660,000 deaths in 2023. And I think to put this in a global perspective, hypertension is actually the leading modifiable metabolic risk factor for cardiovascular disease and all-cause mortality throughout the world. So with this in mind, we're going to kind of walk through how we can optimize the treatment, the diagnosis and treatment of hypertension to reduce heart, kidney, and brain-related conditions. So hypertension in the United States, it's quite common. That's no surprise, I'm sure. Hypertension affects about 50% of U.S. adults. There are some minor differences between men and women, and we typically see an earlier onset of hypertension and actually a slightly higher prevalence among men compared to women. We also know from the epi data that hypertension disproportionately affects our non-Hispanic Black community compared to other racial and ethnic groups. And in addition to that, as we'll talk about later, that also leads to underdiagnosis and undertreatment. So at the end of the day, we want to know, do we have great evidence that reducing blood pressure actually improves outcomes? Does it reduce risk? Blood pressure is a surrogate marker that we use to look at the risk for cardiovascular, kidney, and cognitive disorders. But what does the data actually tell us in terms of the benefit of blood pressure reduction? So blood pressure reduction from a cardiovascular perspective has been evaluated using observational data, clinical trials, meta-analysis data. And the conclusion of that analysis of looking at everything is basically that for about every 5 millimeters of mercury in lowering of systolic blood pressure that we achieve, we see about a 10% relative risk reduction in the risk of cardiovascular disease. What's important here is that the benefit of this uh, risk reduction is consistent in patients whether they have cardiovascular disease already or not. So regardless of that baseline cardiovascular disease status, patients still benefit. What I think is even more interesting and has really come to light over the past, I'd say 5 to 10 years, is that reducing blood pressure actually does reduce the risk of dementia. And this is supported by both clinical trials and meta-analyses. And basically, we see about a 12 to 19% reduction in the incidence of new onset dementia. What's also interesting is that it really only takes a few years of intensive blood pressure treatment to see this benefit. So it is a benefit that occurs early. And so if we think about identifying individuals at midlife who maybe are at risk for dementia in the future, hypertension management, reducing blood pressure is proving to be an effective strategy. So based on that foundation, we're going to shift into talking about some updates as it relates to the diagnosis of hypertension. And I'm sure you've seen these blood pressure categories, which changed back in 2017 with our prior hypertension guidelines. And essentially, normal blood pressure continues to be a well-controlled systolic of less than 120 and a diastolic below 80. So in looking at this table, I think the third column, the qualifier there, is really, really important because for normal as well as elevated, both of those categories, there are requirements that have to be met for both systolic and diastolic. However, when we look at diagnosing patients with hypertension, either an elevated diastolic or an elevated systolic blood pressure is sufficient to diagnose someone with hypertension. So stage 1 is when the systolic is between 130 to 139, diastolic 80 to 89. And then stage 2, of course, since 2017, is when the systolic is 140 or greater, or if the diastolic blood pressure is 90 or greater. Another change was the language around, well, what about when the blood pressure is really high? So hypertensive, urgency, emergency, these terms get thrown around interchangeably, but really we're calling it hypertensive emergency now. And basically this is when the systolic, again, is higher than 180 and or the diastolic is higher than 120. So obviously this is an important kind of foundational concept in terms of blood pressure control. And of course, this shift happened in 2017. and again, drives a lot of our therapeutic decisions today. I've got a note here at the bottom as well. Something that has changed as well is how do we define hypertension among those individuals that are pregnant? And that is now defined as a systolic of 140 or greater and or a diastolic of at least 90 millimeters of mercury. So now that we have the categories in mind, what about diagnosis? And a big change in recent years is really shifting away from just relying on office or clinic measured blood pressure. We know, we hear this all the time, right? Patients come in and they're in this sterile kind of medical setting that they're not used to. Maybe they were running late to their appointment, or maybe the provider was running behind. Or they're at the busy pharmacy and they're not really in a great state of mind, so to speak, to have their blood pressure measured. So a big push in recent years is to really take our office-based or clinic-based measure and combine that with out-of-office blood pressure measurements. And this can be done one of two ways. The 24-hour ambulatory blood pressure monitoring, pictured here in the top right, is where the patient has a traditional cuff put on that's attached to a monitor that typically takes the blood pressure automatically about every 30 minutes throughout an entire 24-hour period. This is a little bit labor intensive for the patient. These devices are not inexpensive, and so this is not routinely done, but certainly is available in some areas. Home blood pressure monitoring is probably what we see used most commonly to confirm a hypertension diagnosis. And of course, this is where the patient may measure their blood pressure at home, or maybe they're enrolled in a program at a pharmacy or other type of setting. One thing that was in the guidelines was a specific statement around cuffless blood pressure devices. And while this has been a research focus for many, many years, and we've got a number of devices that maybe are available that have been cleared by the FDA, we don't yet have a device that we feel confident in really recommending globally for diagnosing hypertension. And so right now, the guidelines do not recommend cuffless blood pressure devices, but I could see this changing in the years to come. A question I get asked often is, well, if a patient is measuring their blood pressure at home, how should they do it? What's the protocol? And the guidelines are very helpful here in recommending two readings taken 1 minute apart twice a day for 3 to 7 days. One thing I see often is patients over checking their blood pressure, or maybe they've checked it for a period of time and then they stop, and then they don't have that follow-up visit with another provider for a month. And that's not very helpful, right? You want recent data. So I tend to really push patients to think about their next appointment or follow-up appointment and then work backwards from there and really making sure that that week before, at least, that they're following this protocol. This protocol allows us to gather enough data to feel confident at what the home blood pressure is actually running, but it also doesn't burden the patient with taking their blood pressure excessively. Now, once we get all this data, what do we do with it? And this is something else that has changed. Not all patients with hypertension are the same. There are various phenotypes based on what the office blood pressure and what the out-of-office blood pressure looks like. So that's also categorized based on whether or not they're actually taking antihypertensive medication. So if they're not, then we classify them as either sustained normotension, sustained hypertension, masked hypertension, which is very interesting because the office blood pressure is normal, but the out-of-office blood pressure is high. And then white coat hypertension, which you're probably very familiar with, where the patient's blood pressure is elevated in the office. They go home in a more relaxed setting and their blood pressure is completely fine. Now, for those taking antihypertensive medications, we have controlled hypertension, uncontrolled hypertension, masked uncontrolled hypertension, and what we refer to as the white coat effect. And what is recommended is that we think of beyond just saying the patient has hypertension, but maybe trying to sort of identify that phenotype, combining the office data and the out-of-office data to have a true understanding of, A, does the patient have hypertension? And if so, are we dealing with a situation where the patient has high office readings, but maybe the normal at home, vice versa? So very helpful information that can really inform treatment decisions. Secondary forms of hypertension, the guidelines are very clear about making sure that clinicians are considering these secondary forms. Some of the most common, certainly, I think one that we all see a lot in practice is obstructive sleep apnea. I've seen a lot of patients, once they get appropriate treatment for their sleep apnea, even come off of blood pressure medication in some cases. Chronic kidney disease, primary aldosteronism, which we're going to talk a lot about because the guidelines are very proactive in really pushing clinicians to do a better job of screening patients for hyperaldosteronism, drug or alcohol induced, and of course, renovascular hypertension. Some other uncommon causes, so thyroid disorders can certainly uh, disrupt blood pressure. Pheochromocytoma, which I know we all learn about but rarely see, but it does exist, just quite rare. And then there's a list there of other types of uncommon causes that can contribute. So important to rule these out because many of these secondary causes, if they can be directly addressed, we can actually manage the blood pressure by treating these underlying causes. So as I mentioned, the guidelines really emphasize the importance of aldosteronism screening. Uh, One of the challenges in the past is that there was this idea that hypokalemia was this marker we could use to identify patients with hyperaldosteronism. The challenge is that many patients can have hypokalemia and not have hyperaldosteronism. And then the opposite is also true. So it's not a very reliable way to sort of cherry pick those patients that you want to screen. So what is really recommended is especially in those treatment-resistant hypertension patients, once we've ruled out other causes, is to make sure that we screen them. One barrier that often comes up is, well, what if they're already on blood pressure medications? The guidelines are clear that it is okay to continue antihypertensive therapy while you're screening patients. The only exception here, of course, is the mineral corticoid receptor antagonists, so spironolactone, eplerenone, et cetera. Ideally, if the patient's already on one of those drugs, that should be stopped about 4 weeks before screening. A positive test can be done multiple ways. So renin or renin level, we're not going to get into how to, we all might disagree on how to pronounce that. But if that level is less than 1, if the aldosterone level is 10 or greater, and then I think what we use more commonly in practice is actually looking at the ratio of aldosterone to renin. And if that's 20 or greater, then that would indicate a positive test. So that's kind of the overview of the diagnostic parameters of hypertension. And I want to shift now into talking about treatment goals, which I know some are somewhat of a moving target, but I think they're certainly evolving in the right direction here based on the data. So the guidelines are pretty clear that a systolic blood pressure goal of at least below 130 is recommended for all adults. There's that door that's open here to say that less than 120 is encouraged. And if you actually look at the cardiovascular section of the ADA standards for managing diabetes, there's a similar recommendation to consider below 120. Of course, that's only if that can be safely attained and if it's feasible. Diastolic blood pressure goal continues to be less than 80. So in general, for the majority of our patients, it's less than 130 over 80. We go a little bit lower if it's feasible and safe. How do we get here? Where did that number come from? And I think it's important to note that there have been multiple trials now looking at this. We talk about SPRINT a lot, which was really one of the big first trials to demonstrate the value of more intensive blood pressure goals. But there have been several other trials since SPRINT in various populations. And so now we have trials representing over 80,000 participants. And when we look at the benefit to harm ratio, it's quite clear that the benefit outweighs the risk. And I think this is a very important concept that we're looking at more and more, or at least trying to frame recommendations in this way and communicate recommendations to patients and thinking about nothing we do in healthcare is completely without risk. And so we definitely have to consider that, but we also have to think about the significance of the benefit. And if you look here across the spectrum of benefit, whether we're talking about cardiovascular events or stroke, new onset heart failure, dying from heart disease, more intensive blood pressure lowering is better. Yes, there is potential harm, as there is with any intervention, and so we have to weigh that. But if you look at the very bottom here of this forest plot, you see that when we look at the major risk of cardiovascular events compared to the total number of adverse events or harm, you can see that it certainly favors more intensive treatment. And so this is kind of where we are in terms of our blood pressure goals and what's recommended for most adults. A really important change in the guideline was a class 1A, which is our highest level recommendation in that adults with hypertension, that a goal of less than 130 for systolic blood pressure is recommended to prevent mild cognitive impairment or dementia. This is really important. It's something that I'm talking about with patients frequently now, getting them to think beyond just the cardiovascular and kidney related risk. This has really been helpful in terms of getting patients to engage a bit more and be more motivated to take their medications. Because I think that the public awareness about cognitive health, the risk of dementia, the unfortunate rise of neurocognitive disorders is something that, most of us are a bit scared of, right? And so there's a lot more reason to engage. So this was a big change, major recommendation, and something to certainly keep in mind. So if 130 over 80 is the goal, how well are we doing? And unfortunately, not that well. Only 1 in 4 adults with hypertension are controlled, and that control there is used as 130 over 80. A lot of our quality metrics are still using 140 over 90 as the cutoff. And so if we use that, we only find out that nearly half with uncontrolled hypertension have a blood pressure above 140 over 90. So we're not really doing a great job, regardless of what cutoff you use. To go a step further, when we look at the breakdown by race and ethnicity, you can see that the highest proportion of individuals with controlled blood pressure is among the non-Hispanic whites. And so we look across different minority groups, you can see that our control rates deteriorate, indicating a major healthcare disparity that warrants a lot of attention and research to kind of identify the best approaches to try to overcome this. Managing hypertension should be easy. It's pretty easy to measure blood pressure. Patients are pretty familiar with managing hypertension. We have a lot of very cheap and inexpensive drugs that work fairly well. We have great evidence to support using those medications. At the same time, there's some factors against improving blood pressure. This is an asymptomatic disease, as I mentioned before, so there may be less urgency to engage. A lot of individuals will require multiple medications. And so we have to worry about polypharmacy, pill burden, adherence. Social determinants of health play a huge role in a lot of factors that contribute to elevated blood pressure, such as food insecurity, or even just having a safe, relaxing space for exercise. Is the home environment safe? And then, of course, therapeutic inertia. So clinicians, we have a role to play in this as well. Therapeutic inertia is when there's a lack of therapy intensification when that blood pressure is uncontrolled. Hear all the time, patients can think of lots of reasons why their blood pressure is high that day, and maybe we should just wait on changing their medication. And so we continue to sort of, kick the ball down the road, so to speak. And so, again, this should be easy, but it's really not. And that's kind of where I think the guidelines, this most recent update, are really trying to be helpful and trying to give some advice in terms of overcoming some of these barriers. So let's transition to talking about the management of high blood pressure. And one of the big changes was the incorporation of the PREVENT-CVD Calculator. This is available through the American Heart Association. There's a website. If you just Google it, you can find it pretty easy. It is also now available on the American College of Cardiology's ASCVD Risk app. That's available on both Google Play and the Apple iTunes Store. This replaces the prior ASCVD Risk Estimator Plus, also referred to as the pooled cohort equation. The reason for this change is that we're really thinking beyond just ASCVD risk. This new calculator incorporates the risk that we all are familiar with, we see in patients, that's associated with the full cardio-kidney metabolic disease spectrum. And I'll use this as a plug for the newly released cardio-kidney metabolic guidelines that were just released by ACC and AHA as well. This calculator was based on more contemporary observational evidence, more diverse population that's more representative of the United States today in 2026. And at the end of the day, it's simply a bit more accurate than the prior calculator. Some of the key changes, the output again expanded, not just focused on ASCVD risk, but it will calculate the overall cardiovascular disease risk, ASCVD only, which is what we use to assess the potential benefit or need for statin therapy in primary prevention patients. It also looks at heart failure risk, and preventing heart failure has fortunately it's in really many of our guidelines, and it's finally getting the attention that it deserves. And reducing blood pressure is one of the most effective ways we have to prevent heart failure. It also lowers the age limit for that 10-year risk estimation. With the old calculator, we could only do 40 and above. With the new calculator, even in a 30-year-old, 35-year-old, you can actually calculate that 10-year risk estimation. So that will allow us to identify those higher risk patients to start treatment earlier, which is really what we're trying to do, because prevention can't start once the disease process takes place. It should really start before then. It also removed race and ethnicity because this is just not a biological cause of disease. Instead, the PREVENT calculator incorporates zip code to account for the demographics, the socioeconomic environment that you live in, which is probably a bit more predictive of risk. It also added body mass index and kidney function, again, to bring in that kidney and metabolic disease risk component. You can also optionally include the urinary albumin to creatinine ratio, hemoglobin A1C, and as I mentioned, the zip code. And we'll talk about how this gets applied to hypertension in a moment. This is what it looks like. So if you go to the calculator on the AHA website, you can see at the top here, there's all the required fields. At the bottom, you've got those three optional ones. What's really important is at the very top. So here I've selected this total cardiovascular disease risk, which includes ASCVD and heart failure. If you want to just look at ASCVD risk, because you're thinking about a patient where you're determining if they may benefit from a statin, make sure you click that button. Okay. It's an easy mistake to make. And then, of course, there's the heart failure tab as well. And it does give you a 30-year risk as well. And it's great to calculate all three of these values for patients. And so they get more information to really understand the full spectrum of risk, not just their ASCVD risk. So one thing we always want to emphasize with treatment is addressing issues related to lifestyle, so psychosocial aspects of care. So weight loss is profoundly effective in reducing blood pressure, low sodium diet, potassium-based salt substitutes, or even just trying to increase potassium in the diet by increasing the intake of fruits and vegetables has also been shown to reduce blood pressure. Reducing or abstaining from alcohol, a lot of the recent recommendations were a little more flexibility if it was okay to have 1 or 2 drinks or maybe 2 to 3 drinks per day on average for an adult. That's really shifted now to, if possible and preferable, to really minimize or even avoid alcohol. Increasing physical activity, and then, of course, stress reduction, which is highly effective, but can be difficult to do. And so it's really trying to do as much as possible to optimize as many of these lifestyle and psychosocial aspects as possible, hoping that cumulatively you do get some improvement in blood pressure. As we all know, most patients may not get to goal with these approaches alone, and so that's where pharmacotherapy comes into play. Initial antihypertensive selection. So for most adults with a blood pressure below 140/90, we're going to start with a single first-line agent. The guidelines, the evidence is pretty robust in that our first-line agents should include one from the following classes. So either a thiazide type diuretic, a long-acting dihydropyridine calcium channel blocker, such as amlodipine or felodipine, and then, of course, our ACE inhibitors or ARBs. Now, if you have stage 2 hypertension, two first-line agents is recommended because the majority of patients are going to need at least two drugs to get to goal. We can also minimize side effect risk if we use two drugs at lower doses while still maximizing blood pressure reduction. The guidelines are really intentional about pushing the use of single pill combinations. Surprisingly, these are underutilized. Think of several practical reasons why that might happen, but these are readily available and should be used in as many patients as possible because it reduces the pill burden, makes things simple for patients, and ultimately improves adherence. There are some selected revised and new recommendations I did want to touch on. And so this is the big one as it relates to the PREVENT calculator. So in someone without clinical cardiovascular disease, so they're a primary prevention patient, and their blood pressure is not at that 140/90 threshold, we can calculate their 10-year risk. And if it's less than 7.5%, the guidelines recommend a trial of 3 to 6 months of lifestyle intervention. But if that's not effective, then you should go ahead and proceed to starting antihypertensive therapy. This is a change in the prior guideline. There's really an emphasis on kind of a longer term attempt with lifestyle intervention. Not quite so eager to go ahead and start drug therapy. And you can see here at the bottom, in the older recommendation, it was based on the 10-year ASCVD risk and a different blood pressure threshold. And so basically, this is opening up the door to initiate therapy and think about prevention earlier and using the PREVENT calculator instead of the ASCVD risk estimator. I mentioned the cognitive impairment and dementia recommendation, and the big change here was that this was a class of recommendation, a 2A recommendation, which means we have some observational data. We don't have any randomized type trial evidence. We don't have robust observational data. And so they upgraded that recommendation to a class of recommendation 1 or strong recommendation. Again, and those are the things that we should do in the majority of patients because the evidence supports it. Secondly, in adults with the resistant hypertension, I touched on this. So really pushing the screen for primary hyperaldosteronism, continuing antihypertensives except for the MRAs. And this is a COR1 strong level recommendation. It's a new recommendation. So in those treatment-resistant patients, we should be much more proactive in really screening everybody. One thing I wanted to do was go through, we have a lot of drugs in hypertension, and I think, especially from a pharmacist perspective, we're trying to optimize medical therapy. We're not just trying to recommend a drug, we're trying to select the best drug for that patient. So I wanted to revisit some unique characteristics of different medications within different classes. So the thiazide type diuretics, which are among the first line options we should consider. Some big differences between these three. Hydrochlorothiazide, overwhelmingly the one that we use the most. It's available in more single pill combinations. It's generally pretty well tolerated. We're all very familiar with it, but it does have a short half-life, and it does not have quite as a robust blood pressure lowering effect as we would like. Contrasting that with chlorthalidone, much more potent in reducing blood pressure, has a much longer half-life, more durable 24-hour blood pressure control. It's been used in a lot of our outcome trials. It does, however, have a higher risk for adverse effects, particularly hypokalemia, hypotension. We have very few single pill combinations available. Even dosing it is challenging because ideally, I think we'd like to start at 12.5 milligram a day because of that increased potency. It is available in a 25 and 50 milligram tablet, but asking a patient to cut chlorthalidone tablets in half is difficult. If you've not tried it, you should because it's nearly impossible. Indapamide, I think, is one that gets underutilized, and it's one that I use quite a bit nowadays because it's kind of the middle ground. We get great potency. It's got a long half-life as well. It's very well tolerated. It's also been used in a lot of outcome trials. The big downside, of course, is no single pill combination, and clinicians aren't familiar with using it or dosing it. So we don't have a perfect thiazide type diuretic, but I think the main point here is that when possible, clothalidone and indapamide do have advantages and should probably be prioritized when possible over hydrochlorothiazide. The ACE inhibitors, so lipophilicity comes up a lot, and one of the hopes with that is that the more lipophilic agents would have better vascular tissue penetration and therefore better effects. Maybe there's some modest clinical significance to this, but I think clinically it's typically not convincing enough because you don't see a lot of ramipril or perindopril used in practice. Renal clearance, so we know that ACE inhibitors are renal protective or nephroprotective. We also know that when we first start an ACE, we may see that mild bump in creatinine and a mild decrease in GFR, but over time, we see that normalize. Most ACE inhibitors are renally cleared. One exception is focenterpril, which is partially metabolized by the liver. And so if you have a patient with more baseline kidney dysfunction, focenterpril, can be useful in those patients. Lisinopril is what we use though, right? In clinical practice, it's simple, it's cheap, it's once a day. We're familiar with it. Ramipril arguably probably has the best outcomes data, especially in high-risk patients. Perindopril, in terms of its durability and the duration of its effect, probably provides the smoothest 24-hour control. Enalapril and captopril are really using very little today, given that they require multiple daily dosing that's inconvenient for most patients. The angiotensin receptor blockers. So this is one that's always fascinating to me. Losartan is sort of, and maybe valsartan to some extent, are used a lot. I see a lot of losartan in practice, but in reality, it's actually the least potent ARB when it comes to blood pressure lowering. Irbesartan, valsartan, better. And actually, some of the later ARBs that have come out, azilsartan, telmisartan, olmesartan, even candesartan, are actually a bit more potent with blood pressure lowering. So something to consider again in terms of trying to optimize therapy. Losartan does have that benefit in that it does reduce uric acid levels. So in a patient that also has gout, that could be useful. Valsartan and candesartan have the most robust heart failure data. So in our patients with heart failure and a reduced ejection fraction, we want to prioritize those. Telmisartan is a partial PPAR gamma agonist. So we do see some modest improvement in insulin sensitivity. Clinical significance of that's probably fairly moderate at best. But again, something to consider in those patients with prediabetes or diabetes. The calcium channel blockers. So always get divided into dihydropyridine and non-dihydropyridine. Big difference here is that the dihydropyridine calcium channel blockers are really vasodilators. They act on smooth muscle. They don't interact with the conductivity of the heart. So there's not a decrease in heart rate. And actually, we can see a little bit of reflex tachycardia because of the vasodilation and maybe even some mild edema, which we see in practice. These drugs do have an anti-anginal effect. So in patients who continue to have angina despite beta blocker therapy, these are reasonable add-ons. They're not harmful in heart failure with reduced ejection fraction, but they're also not beneficial from a heart failure perspective. Verapamil and diltiazem, much greater effect on cardiac myocytes and conduction tissue. So we actually do see reduction in heart rate. They are not recommended if the ejection fraction is below 40%, because the last thing we want to do is decrease heart rate or heart contractility. And verapamil and diltiazem act on calcium channels within the myocardium, and so we don't want to use those. They're both moderate inhibitors of CYP3A4, so we do have to be considerate of drug-drug interactions. So moving on to medication adherence. So like I said, a lot of medications we can use. Patients with hypertension are often on several antihypertensives. So non-adherence is a common issue. As I mentioned, dose consolidation, single pill combination, when possible, using once daily versus multiple times a day medications. That's why captopril and enalapril, of course, have fallen out of favor. Medication reminder aids, whether it's the phone, electronic pill bottles, um, even just a paper calendar, some kind of reminder system. Regardless of any of these methods, my approach is always to figure out why is the patient not taking the medication consistently or appropriately, because then you can match a strategy to the reason. Throwing a pill box at someone who maybe doubts the benefit of lowering their blood pressure or has some other reason that's really driving it, that pill box is not going to solve the problem. So diagnose the cause of non-adherence, and then I'd match that with a solution that's appropriate to the cause. Resistant hypertension, we've touched on a little bit. I did want to revisit, how that's defined. And these patients either have an office blood pressure that's still not a goal, and they're on at least three antihypertensives. And typically that's going to be one from each of our first line drug classes. So an ACE or ARB, a CCB, or a thiazide diuretic. Now, if their office blood pressure is at goal, but they are requiring four or more medications, those patients also have resistant hypertension. However, not all resistant hypertension cases are the same. One of the big first steps is really excluding pseudo resistance. So, are the blood pressure measurements accurate? Are they taking their medication? Do we have blood pressure readings outside of the office to rule out the white coat effect? We want to think about other reversible contributing lifestyle factors. Maybe they're drinking, 12 cups of coffee every day or downing energy drinks, minimizing interfering substances, particularly illicit substances, and then, of course, screening for secondary causes. If we've identified true resistant hypertension, what do we do? So the first step is if they're on HCTZ, replace it with a longer acting thiazide diuretic, clothalidone or indapamide. I've seen this in a number of patients really make a difference. So I really do believe that's a very easy, simple thing to do. The next kind of number of options include adding an MRA, um, using clothalidone if it's not been started already, or even a loop diuretic if they have chronic kidney disease, stage 4 or higher. A lot of the hypertension in those patients is driven by volume retention, so removing that volume can be effective. Adding agents with different mechanism, that's a cornerstone of hypertension management. Using one drug and going up and maxing it out on the max dose is just not going to work for most people. We really got to use multiple drugs at low to mid doses to reduce the risk of side effects and using drugs with different mechanisms of action. Potent vasodilators really become kind of that last tier option, including some newer options we have for treatment resistant hypertension. So the endothelin receptor antagonist, aprocitentan that's out is another kind of more novel option. Hydralazine, even minoxidil in some cases, of course, but a lot of baggage with those medications. And so we're rarely getting there, but there are some patients to where we are considering those. And then lastly, renal denervation is a therapy that's available at some institutions. Very select patients with resistant hypertension. That approach has really not become, the main approach to treating resistant hypertension, but it is available. Orthostatic hypotension. So we're going to shift gears a bit. This comes up a lot, and especially as we think about more intensive blood pressure lowering. How is this defined, right? So this is really when we have a sudden drop in blood pressure when we go from a sitting or lying position to a standing position. If you have at least a 20 millimeter of mercury drop in systolic blood pressure, or at least a 10 millimeter of mercury drop in diastolic blood pressure within 3 minutes of standing, that's how we diagnose orthostatic hypotension. It can be done pretty easily in the clinic or pharmacy or anywhere else. Usually it's symptomatic. Patients will be dizzy, lightheaded, maybe blurred vision. There's a lot of other causes of orthostatic hypotension that you have to rule out. Dehydration's a big one. And it's probably their diuretic if they're on a diuretic. This is one thing that I have had a lot of luck with patients that develop orthostatic hypotension is either reducing the dose or potentially even discontinuing their diuretic can resolve this, or addressing a lack of, a consistent water intake. Just making sure they're well hydrated can also help this a lot. There are other neurological or even other medications that, of course, can cause orthostatic hypotension. How common is this? It affects about 7 to 10% of community dwelling adults. Older adults are more susceptible to it. It is also predictive of adverse health outcomes. What's interesting is actually it's associated with an increased risk of cardiovascular events. Not 100% sure of the connection there, but it is something that we have to kind of identify and address clinically, especially in the older adult population. So how do we do that? The guidelines address this a little bit, and they're very clear that the randomized evidence demonstrates no association between orthostatic hypotension and intensive blood pressure treatment, which sounds counterintuitive. And the guidelines actually recommend that if you have hypertension and orthostatic hypotension, improving blood pressure control is actually one of the most effective ways to treat that. And it's a class 1A recommendation. And the rationale and kind of mechanism here is that by improving blood pressure and lowering it to what we consider to be closer to normal, actually improves vascular physiology, functionality, and responsiveness of the autonomic nervous system, which plays a big role in driving orthostatic hypotension. So that makes a lot of sense. And so in a lot of these patients, what tends to happen is we actually back off of treatment. Now, if they're having syncopal episodes and passing out, that's different. That's not what I'm talking about. But in that patient with little to no symptoms, actually improving blood pressure control is the strategy. We also want to make sure they're hydrated. Basic kind of tips in terms of navigating, moving from a seated to a standing position. Using compression stockings can be very effective. Longer acting antihypertensives can also help, and even dosing blood pressure medication at nighttime can minimize orthostasis. Alpha blockers are the big drugs that we know contribute to this, and so we generally try to avoid those along with the central alpha 2 agonist. And I already mentioned diuretics. Doesn't mean we should avoid them, but if someone has persistent orthostatic hypotension, we may need to abandon diuretics and move on to another class. Pregnancy. So I want to touch on this special population. So again, you can see the systolic blood pressure there, 160 or diastolic over 110, if that's confirmed. Those patients, we want to get the blood pressure down, but we do want to be conservative. And so the guidelines say try to do that within 30 to 60 minutes. If you have chronic hypertension during pregnancy, you can see kind of what the recommendation is there. And essentially now we're starting treatment in those patients with a goal of reducing the blood pressure below 140 over 90. In pregnant patients, labetalol and extended release nifedipine are the drugs we have the most experience with and data with. ACEs, ARBs, atenolol, aliskiren, nitroprusside, and MRAs generally should be avoided in this population. All right, so that was a quick overview of some of the highlights of the hypertension guidelines. And so I do have a patient case scenario just to kind of walk through some application here before we get to Q&A. So this is a 45-year-old presenting for an annual primary care checkup. Blood pressure last year was 126 over 72. It's 134 over 78 today. Only medical history is seasonal allergies, for which he takes fexofenadine for every day. So which blood pressure category does he fit into? And if you go back to the category slide, we have a blood pressure of 134 over 78 today. So that's above 120 over 80, so it's not normal. Is it elevated? Well, the systolic being above 130 kind of gets us out of that category. Is it stage 1? Yes, because that systolic is between 130 to 139. It's not stage 2 because they're below 140 over 90. So this gentleman would be classified as having stage 1 hypertension. So what's the best next step? We can provide education and counseling only, recommend out-of-office monitoring, go ahead and start a single antihypertensive therapy or start two antihypertensives. But we already know that he's stage one, so we're probably not going to want to start two medications today. And because of the patient doesn't have any robust medical history, no prior cardiovascular disease, kidney disease, no diabetes, but we've only got this one reading that's elevated, right? So we first need to really confirm the diagnosis, and that's going to require out-of-office blood pressure monitoring. Now we can do education and counseling, but we shouldn't do that only, right? So we want to make sure we do that out-of-office blood pressure monitoring to confirm whether or not this gentleman has hypertension. So he comes back and he does a 7-day home blood pressure protocol, and the average of those blood pressures is 136/74. What do we want to do now? So we can do education and counseling only. We can calculate the 10-year PREVENT-CVD score, start with a single antihypertensive, or start with two drugs. And as I mentioned, we don't want to start with two drugs because he does not have stage 2 hypertension. But we don't quite know the patient's risk, right? So stage 1, we've confirmed that with home blood pressures. What would really be helpful is the 10-year risk score in this case, because there's no history of diabetes, no history of kidney disease, no heart disease, or anything like that. So we're going to calculate the 10-year CVD prevent score. We do that, and it comes back at 3%. So that's below that 7.5% cutoff. So again, we have similar options, right? We can just go ahead and start treatment. We can do nothing, right? Just recheck the blood pressure in a year. It's not that high, right? That's a common thing that I hear. Or go ahead and start a 3 to 6 month trial of a lifestyle intervention. And so D would be the correct answer here because that 10-year risk is below 7.5%. We don't need to start treatment yet, but we will try the lifestyle. And if that's not effective, then we're probably going to want to think about treatment. So a couple years later, patient's doing fine. They kind of come in for a follow-up, but the blood pressure now is 146/94, and the home blood pressure is 142/90. No diabetes, other labs are unremarkable, no changes in those other medications. What do we do now? We can start with amlodipine, diltiazem, metoprolol, or valsartan HCTZ. Well, now we have a very different situation because we have confirmed data here that he probably has stage 2 hypertension, right? So stage 2, two drugs. So in this case, ideally, we'd want to go ahead and start the valsartan hydrochlorothiazide single pill combination once a day, because most likely this person's going to need a couple of antihypertensives to get to goal. Okay. All right. So a few take-home points, and then we'll get to a few questions. So confirm the diagnosis. Out-of-office monitoring is just really, really important. Aim for a goal of less than 130/80 as tolerated, less than 120, again, if feasible. The PREVENT score is helpful for those primary prevention patients where you're making decisions about risk and treatment. For that low-risk stage 1 hypertension patient, we still want to start a medication if the blood pressure remains above 130/80 after that 3 to 6 month lifestyle trial. ACE or ARB, calcium channel blocker, thiazides still remain first-line agents, really emphasizing the use of single pill combination. Be systematic with resistant hypertension, so screening patients, excluding pseudo-resistance, and using MRAs as appropriate. And really the bottom line, I think, as mentioned here, is that hypertension requires accurate measurements, timely intensification of antihypertensive therapy, a patient-centered approach to dealing with adherence issues, paying attention to secondary causes, identifying them and managing them if they're there, especially primary aldosteronism.